So, okay, Dr. Prachi will be talking on strabismus in myopia.
Okay.
Over
So
to you,
very
Doctor.
good morning to everybody, and thank you, Dr. Shruti, for including me in the IC. So slightly offbeat topic after we have learnt about the control mechanisms for myopia progression. So we're just going to look at some muscle balance issues that can be there. So starting with the first case, there's a 7-year-old boy with the best corrected visual acuity of 6 by 24. My fellow calls me up that this patient is posted for surgery. It's a routine surgery of alternate exotropia with DVD. But what is the main point here? The child has a very high refractive error of around minus 10 to 10.5. The prism bar cover test measures 50 prism exotropia. Now, can we proceed with the usual surgical tables that we use for exotropia? Well, no. There are certain preoperative considerations. So, remember, one mnemonic is minus measures more. So, minus lenses can be considered to have two prisms apex to apex because it's a concave lens, and hence in exotropia, it causes a base out effect. So, in a strabismic patient, only one line of sight at a time passes through the corresponding spectacle lens at its optical center where there is no prismatic power. While on the other hand, through the other line of sight, it induces a prismatic power which causes a prismatic change of the deviation when it is measured with the myopic glasses. So the true deviation in front of the glasses is changed by a percentage of approximately 2.5 into D, where D is the bilateral spectacle lens power. So for this particular case, it was approximately 25% more. So 50 prisms will measure up to actually 40 prisms is what we need to plan our surgery for. There are these tables that are there in all the squint textbooks. So again, our patient had a refractive error of around minus 10. We measured as 50 prisms and the corresponding value is 40 prisms. Another way of eliminating prismatic effect of glasses is just substitute the myopic glasses with contact lenses. Then whatever you measure can be considered as your goal for setting the eye straight. Operative considerations. So we all know that myopes have very thin scleras and hence are at risk for scleral perforation. We need to have a spatulated needle and visualize it completely during the scleral bites. Another option is to use hangback techniques for recession of the muscles. Moving on to case number 2, this is a 6-year-old girl having intermittent divergent squint since 4 months, very common clinical scenario. She ends up with a refractive error of minus 3 after cycloplegia, and her squint seems to be corrected with glasses. Now, favorite question that the parents ask us is what led to what? So, did the myopia come first or did the squint come first? So, it's a classical case of what came first, the chicken or the egg. So let me give you two hypotheses as to what this is based on. So children who develop myopia, we know have a reduced demand for accommodation. Hence, they have a reduced convergence, which leads to an intermittent exotropia. So convergence insufficiency causing an intermittent exotropia. On the other hand, in patients who have intermittent exotropia, there is an increased convergence to try and control the deviation. This leads to an increased accommodative effort, which predisposes them to develop myopia. So what is the effect of myopia on ocular alignment? So one thing that I need to tell you is when we encounter a patient with myopia or any refractive error when the patient has strabismus, first give a pair of glasses and reevaluate after 2 to 3 weeks. Now, over-minus glasses has been used as a treatment for patients with intermittent exotropia. It is preferred in the younger age group. It helps preserve binocularity and defer surgery. And it is most effective in patients of intermittent exotropia with high AC by A ratio. So there was this randomized control trial published recently which studied 386 children randomized to over-minus and non-over-minus therapy. The over-minus group was prescribed minus 2.5 diopters for a year, then minus 1.25 for 3 months, and then non-over-minus spectacles for 3 months. So the results were such that the mean distance control at 1 year was better in the over-minus group, but when the lenses were withdrawn, there was no significant difference in the mean distance deviation of the year as compared to the control group. But a significant finding was that there was a myopic shift that they found in children who were wearing the over-minus glasses. So we have to just keep a watch as to whether their myopia is progressing and whether this could be a factor. Moving on to case number 3, this is a 35-year-old male presenting with squinting of the left eye since childhood. He has a unisomyopia of minus 19 in the left eye. The patient was measured with contact lenses and measured 40 prisms of exotropia with hypotropia. The orbital imaging for the ocular muscles was normal. The patient underwent a regular recess resec procedure and had a good result. So this is a peculiar complex called as the exotropia-hypotropia complex in high myopia. It has been reported by Sumit Munga et al. As a study of 15 patients where the mean axial length was around 30 millimeters. Imaging studies were normal, and a tailor-made approach to the management using regular recession-resection procedures with vertical shifting or the vertical recti gave a good result. A nasal loop myopexy as a procedure in these patients has been reported by Dr. Sandra and group. Intraoperatively, they found that the parts of superior rectus and medial rectus were deflected, and instead of adding a vertical rectus to correct the hypotropia, they did a loop myopexy and found significant improvement of limitation of elevation in abduction.
Doctor, can you
Case
please
number
summarize?
4, yeah, last case. So 50-year-old male presenting with gradual progressive inward deviation of the eye. He has undergone cataract surgery, very large globes. The right eye is fixed in ET and has no abduction. Orbital imaging revealed shifting of the SR nasally and lateral rectus inferiorly. So this is a condition called as myopic strabismus fixus. A loop myopexy was done where the deflected parts of the SR and LR are corrected by either sutures or silicone band loop around 14 to 15 millimeters behind. And this patient did well in the long term. Last case, 18-year-old female with intermittent squinting, minus 3.5, wishes to undergo LASIK. So the evaluation for this is extremely important because sometimes the patient can decompensate to a manifest strabismus. So few points to keep in mind is do a cycloplegic refraction, make sure the glasses that the patient is wearing is correct and the difference is within 0.5 spheres. Cover test needs to be performed with the correction in place. Use contact lenses to simulate the refractive result and measure fusional amplitudes, which is extremely important. So if the fusional amplitudes are less than 18 to 20, there is a good chance that the patient can decompensate. So if the fusional amplitudes are less and the manifest deviation is more, it may be a good idea to correct the strabismus before the LASIK. So to summarize, keep in mind the reliability of the measurements with prisms. The effect of myopia on ocular alignment should be tried. Precautions to be taken during surgery with respect to scleral perforation. Take into account the anatomical shape of the globe and the muscle placements and use orbital imaging judiciously. Thank you.
Thank you, Dr. Prachi.